Hi, my name is Julia Gabalski, and I'm going to be presenting on Parkinson's disease. My other group mates are Kelly, Jojo, Autumn, and Nicole. Ready? So our table of contents, we have causes, symptoms, stages, and treatment. We're going to go through each one of these. A little introduction, Parkinson's disease it often slowly progresses over time, with symptoms being barely noticeable at first. 90% of people, or most people, are diagnosed when their disease progression is already 90% of the way there biologically. And then the signs will present as showing little expression, slurred speech, and little to no facial expression. Over 90,000 people are diagnosed in the US with Parkinson's each year, and over 10 million people worldwide are living with Parkinson's disease. All right, our patient is a 72-year-old male diagnosed with Parkinson's disease at age 60, which is technically early onset. Anything past Parkinson's disease diagnosed past 65 is regular later onset, but before 65 is early onset. His signs and symptoms were bradykinesia, or slowness of movement, and then he has primary progressive aphasia, which means that his speech is non-fluent, it'll kind of stop, and it takes a lot of effort, and it's softer. It's harder to hear, and his earlier signs and symptoms that brought him in were the tremors and the flat affect. So personal and family history, was diagnosed at age 60 after frequent falls and an increasingly unsteady gait, which you'll see a lot of the times, a little bit of a shuffle as people try to walk. And then they have a family history of the PARK7 mutation that's been found to be correlated with Parkinson's disease. Like I said, the population frequency, over 10 million people worldwide have Parkinson's, and of that, we know that 10 to 15% have the genetic form of the disease, and I believe that percentage will increase as we learn more about the genetics behind Parkinson's, because there's still a lot of active research going into Parkinson's disease and the genetic causes. We do know that risk factors are, if you're an Ashkenazi Sioux or North African Arab Berber, you're more likely to carry these Parkinsonian genes. And then men are more frequently affected than women and we think that estrogen might play a neuroprotective role. Okay, and this is a pretty typical presentation of Parkinson's, and we'll go into more comparing our patient versus the normal progression. Okay, so genogram of the disease. Down here he's 72 years old, and Parkinson's follows an autosomal recessive. So he has the two small little p's. He's still alive. He has a male sibling, so he has a brother that's 68 that's still alive. Both parents are deceased. One died of a stroke, and both were carriers of this PARK7 mutation. And you go back to the grandparents' generation, so the first generation, and the grandfather had an age of onset of 64, so almost regular onset, but technically early onset. The age of death was 78, and we are assuming a PARK7 mutation, but this would have been prior to access to the genomic information. The genetics for Parkinson's has been discovered since the 1990s, when we were doing that huge genogram mapping. And then we have the other side of the family as well, and none of them are affected or carriers. All right, and then let's go into how we are diagnosing Parkinson's disease. So there's a genetic way, and then there is a clinical diagnosis way. The clinical diagnosis way is the most common. That's where you collect patient history and you collect their symptoms. They have those hallmark symptoms, then they're more likely to have Parkinson's. So then you start them on a dopamine replacement or an L-DOPA treatment. And if they're responsive to that treatment, then it indicates that they're more likely to have Parkinson's disease. And there's two other forms of a clinical diagnosis. There's a DAT scan, which was approved in 2011 by the FDA, and that's where you look for these dopamine transporters, and you can have a visualization of how much dopamine is in the brain. So on the bottom right here, you can see the DAT scan of a normal patient versus the DAT scan of someone with Parkinson's. You can see on the right, there's less dopamine within the brain, and it's similar to an MRI, where you can really visualize the disease progression there. And then there's a SIN1 skin biopsy test, and it looks for the presence of certain phosphorylated proteins that indicates that you might have Parkinson's, so that you can take a skin biopsy from your back, from different areas of your body, in the legs and on your skull as well. And that if it's inputted properly, then that's covered by Medicare, which is important to note because a lot of these genetic diagnoses are not diagnoses forms are not covered by Medicare, and they're often very expensive. So when you're talking to someone as a nurse, you might be more likely to have this clinical diagnosis pathway, because it can be covered by Medicare, and a lot of these L-DOPA, a lot of these hallmark treatments are covered by insurance now, because Parkinson's disease is the second most frequent neurological disorder or neurological disease behind Alzheimer's. So it's very common and often covered. So let's go into the genetic diagnosis. Parkinson's disease has the single nucleotide polymorphisms that have been identified. You can see in the top right chart here, there are those point mutations. So like Parkin, LRRK2, PINK1, SNCA. So what this chart is showing is that if you have these point mutations, that means as you go further to the right, you have these point mutations, and they are more likely to indicate that you will have Parkinson's disease. And then you can have these really common risk variants, like environmental exposures to toxins, that might indicate that you have Parkinson's. So there's research conducting genome-wide associated studies that use genetic metadata to look at these point mutations in correlation with environmental factors, in correlation with these other point mutations that we might not have considered yet. And so these studies statistically analyze the incidence of these point mutations against the phenotypic presentation of Parkinson's. And then lastly, for the genetic diagnosis, the Parkinson's Foundation is running a Mapping the Future study that has over 10,500 participants. That's for people who have been diagnosed with Parkinson's disease. And then they get sent a little test kit, and you send in your genetic information, and you're a part of this study, and you get free genetic counseling within 6 weeks of sending your test kit in. And Parkinson's Foundation is hoping that by collecting more data, getting more participants, we'll have a better understanding of the genetics of Parkinson's disease. But for right now, we're not 100% sure of what causes Parkinson's. So we're still going into some research. Okay, so there are genetic causes, which accounts for 10 to 15% of people with Parkinson's disease, and then there's unknown causes. But we do know that Parkinson's disease is highlighted by a dopaminergic neuronal loss in the basal ganglia system, which basically just means that the neurons that produce dopamine in your brain aren't able to do that as much anymore. And so here's a little picture of that. So we'll see the subthalamic nucleus and the substantia nigra are not able to produce dopamine as well, which goes into this whole system. And especially in the striatum, you'll see some effects where people are not able to initiate as much movement because of this loss of dopamine. The sporadic form is most common. I said 85 to 90% of people will have a sporadic form. I believe that number will decrease, and we'll actually find that people have more genetic component as we look at maybe utilizing AI, or we're looking at this utilizing AI to statistically analyze some of these point mutations. I think that there's a lot out there that we can still research into. And you can actually look at the interaction of genetics and toxins within the environment to see if that might play a role, but we're not 100% sure. All right, some symptoms. So slow movement, tremors, and rigidity are hallmark symptoms of Parkinson's, and our patient has all three of those. And there's motor and non-motor types of symptoms. All right, so motor is bradykinesia, which is slowness of movement. You might be almost like frozen, kind of like this. You'll see some tremors in the hands and in the lower extremities. That's actually a part of the Unified Parkinson's Disease Rating Scale, is to have those tremors. That's a way of diagnosing and indicating that you have Parkinson's. You'll have a mask-like face, so they might not be as expressive, and frequent falls and shuffling gait. The frequent falls and shuffling gait is what brought our person in to be diagnosed by a neurologist with that unified Parkinson's disease rating scale. Some non-motor symptoms that we'll go into a little bit more: depression and anxiety. You'll see a softer, lower voice. It might be hard to hear them, or if they have a side effect of the medication called dyskinesia, they might have a little bit of warbling in their voice. You'll notice some GI disturbances. It's important to note that there's a brain-gut connection where some of the neurotransmitters like dopamine or serotonin are actually found in our gut as well. So if you give someone a tablet or a capsule, or even just within their disease progression, you might notice some constipation, some different bowel movements, especially after administering medications. And in some forms of Parkinson's, you do have dementia. So you'll see the memory impairment or just changes in personality and behavior. There's a little picture as well to show some of the common symptoms. All right, let's go into stages. Early, mild, moderate, advanced, and severe. In early stages, you're still up and walking, you're still pretty independent, and then you'll get into the complicated stage. Stages 3 and 4, you might need more help with ADLs, and then with the later stages, you will need a lot of assistance. So stage 1, mild symptoms that normally don't interfere with daily activities. They might not even think to go into the doctor's office, but you will see one-sided differences with tremors and changes in their posture or walking. One of the other patients that I know of has noticed differences with their left arm after a fall, and then that just didn't go away, it didn't get better, and so they asked their doctor, hey, what might this be? And it took like a year and a half after that to even think of Parkinson's disease. But within this earlier symptom, you can look at medications, but it's really important to look at physical therapy, occupational therapy, having consistent and purposeful movement, whether it's dance or physical therapy, assigned movements is really important. It can help maintain muscle mass. It can maintain range of motion and flexibility and balance. It's proven to be very effective. Stage 2, we have worsening of symptoms. The daily tasks might become more difficult and might require more time, but they can still be fairly independent. This is where we adjust the medication dosing. We might need to have speech therapy come into play. Maybe you might notice some difficulty swallowing, or some softness of the voice that might bother some people. So they might work on like doing different consonant practices, or then we'll make some lifestyle modifications. So regular exercise, balanced diet, and adequate sleep, because you might notice some sleep disturbances. So something to note as a nurse is, okay, maybe we can reach out to these different departments. We can check in, see how they're doing, make sure that they have all the resources that they might need connected to this. So for our patient, they have the non-fluent progressive aphasia, get them connected with speech therapy, make sure that they're working those muscles, that doesn't atrophy. And then we have stage 3, which is considered a mid stage, or loss of balance is a hallmark of this stage, and the motor symptoms continue to worsen. This is where they might be a great candidate for surgical interventions, as medication adjustment becomes more difficult, as the therapeutic window for medication just narrows, as you have to increase your dose, the range of what's acceptable to the patient and what doesn't produce symptoms kind of narrows. So it becomes harder and harder to work with your doctors and get the right dosage. And as the disease progresses, it's important to have support groups, whether that's within the region, online, or just looking at their support system and seeing how much they need care, how much their family or friends are able to support them through this disease. All right, in stage 4, now their symptoms are fully developed and severely disabling. They might be able to ambulate without assistance, but they might need to use a walker or a cane. They'll need significant help with their daily activities, and they're unable to live alone, but they might not need to be in full-time care yet. although most people are due to the high incidence of falls. Same thing, medication management, and then that's where we get the walkers, canes, or even the Apex machine where they can pull themselves up, but they're secured into that machine. And then we'll make some home modifications, or maybe an assisted living facility might be safe for them so that they don't have to have tripping or fall hazards. All right, and then we'll go into stage 5. This is the most advanced and debilitating stage. We'll see stiffness in the legs or a lot of dyskinesia, which is the side effect from the medication. And it's impossible to walk or stand. They need total help. This is where they're bedridden or confined to the use of a wheelchair. So the person might be in bed, then we'll use a Hoyer lift or a ceiling lift to get them into their wheelchair. They'll need someone to help feed them and make sure that they don't have any aspiration. A lot of people with Parkinson's will have difficulty swallowing in the later stages. We can consult with palliative care and, depending on their prognosis, hospice care. Some of the medications, which we'll go into, have some side effects, as the dyskinesia or even muscle spasms or pain. And so consulting like palliative care and hospice care is a really great option for these people as they progress throughout the disease. And like I said, they'll need the full-time care. Okay, some non-motor symptoms that we can talk about are mental health. And so 50% of people with Parkinson's develop depression. It's really hard to recognize, though, because they have the flat effect, and fatigue is a part of the Parkinson's disease diagnosis. So it kind of mimics the other signs and symptoms of Parkinson's, and so it's often overlooked and undertreated, but it is important to treat and can help the patient participate in their own disease management. Okay, and then they can have apathy, which can be frustrating for caregivers. They might express that they're not sure how they're going to do it, or if they're just not interested in doing all of these extra treatments. So they might refuse treatment. And then 40% of people with Parkinson's develop an anxiety disorder, and that can look like excessive worry due to the fear of a terminal prognosis. And they are losing some of the dopamine in their brain. So you'll see just neurological and physiological changes as well with that. All right, so some treatment. The gold standard is dopamine replacement therapy. So that's often called a drug called L-DOPA, which is a precursor molecule to dopamine. It was discovered, it was isolated in 1913 by a researcher from a specific plant that I'm forgetting the name of right now, but it was discovered as a treatment for Parkinson's disease in 1967 by George Coetzee. He was doing research down in New York. There's a really great movie called Awakenings that has Robin Williams and forget the other actor's name is, but it's about the discovery of L-DOPA, and I highly recommend that movie. And so this is most often taken orally, but we'll go into some inhalation treatments. It's taken as a capsule or a tablet, and the most effective way that this is delivered is in an extended release tablet with carbidopa as well. And carbidopa is an MAOB inhibitor, which means that it has, instead of getting digested down in your body, it has a chance to get up into your brain and cross the blood-brain barrier and get into the basal ganglia system. And so it's commonly used to control the bradycardic or the slowness of movement symptoms apparent in Parkinson's disease. And it's typically prescribed only when it needs to be, when the symptoms have progressed and become more difficult to control. Because once you start this medication, it's really difficult to stop. And we are trying to learn how to bypass the defective basal ganglia system by using something like the dorsolateral area of the prefrontal cortex or part of the serotonin systems. If you can use a serotonin replacement therapy, might be able to treat some of that depression and anxiety and also help with motor symptoms. That's ongoing research. And so then this allows the patients to perform the correct movements under executive volitional control. All right. And so here's a picture of the basal gang or part of the basal ganglia system. You can see the substantia nigra on the left here has more dopamine in the synapse, and that's a healthy brain. And on the right here, we have less dopamine in the system, and so the MAOB inhibitor, carbidopa, that I was talking about, will work within the synapse here and will stop the body from breaking down the dopamine within the synapse. So then, therefore, you can either retake it up by the presynaptic terminal, or it can go to the postsynaptic terminal. Because normally if there's excess dopamine in that synapse, our body will just break it down, and we want the dopamine to stay in that synapse for as long as possible with Parkinson's disease patient, because they have so much less of it. Alrighty, and then we have 3 surgical options. We have a lesion surgery, deep brain stimulation surgery, and a neural grafting surgery. A lot of times this might be done when someone isn't all the way to stage 5. They may be in stage 3 or 4 when medication is not 100% working for people. You still have to go through a whole candidacy process. All right, so for the lesion surgery, you go in and you burn tissue or parts of the brain that you target, and small lesions are made to help control movement. And the surgery is done while the patient is awake and trying to pinpoint that area of the brain that is causing specific tremors. There's a high risk for the surgery because, say, you target the wrong area and the patient responds inappropriately, then, or not well to the surgery, then you could have some lasting damage there. So as a nurse, maybe you can think, okay, if that person's going to be awake in surgery, do I send someone who's familiar, like a nurse, that can scrub in and help keep that patient calm, help lead them through the surgery? And then same thing with deep brain stimulation. That person is awake, and that's where small electrodes are placed in the critical parts of the brain that control the movement, so in the basal ganglia system. And these wires are connected to a battery pack, essentially, underneath the skin that sits right here above the chest, threaded up through the neck and down into the brain. And people do this surgery without any sort of medication. So they come in very stiff, very rigid, and fine-tuning that electrode signal is pretty hard. It'll take a few visits. It'll take some inpatient case management to be able to get the electrical pulses just right. And then there's neural grafting. That's where we're putting in something like stem cells, trying to see if we can regenerate any sort of function within the brain. All right, here's deep brain stimulation. You can see that there's that pack right here underneath the skin, starting it down deep into the brain to find the electrode. And that's what the OR might look like. They'll monitor your ECGs, your brain waves throughout the surgery. I'm saying that properly. As you're going throughout, and they might have you try to do some sort of movement. I've seen it where, like those videos where they might squish a ball or play their instrument, just to be able to see that they're in the right spot. All right, then we have some ongoing trials. IRLab mesdopetam. It's a medicinal trial testing the efficacy of mesdopetam as a therapy for the dyskinesia in patients with Parkinson's. So patients with Parkinson's will get the dopamine replacement therapy, such as L-Dopa, and it has a common side effect of dyskinesia, that excessive movement. And so this is treating a side effect. This new trial is treating a side effect of the dopamine replacement therapy. There's a lot of studies like that because L-Dopa has been used now for over 40 years. So dyskinesia is a well-known side effect of dopamine replacement, and there's a lot of trials trying to mitigate that. So as we go up in dosage of L-Dopa, we can make sure that the dyskinesia isn't worse. All right, and then we have an N-methyl D-aspartate receptor, NMDR, modulator that enhances synaptic plasticity. So it's hypothesized that targeting these receptors might be an effective approach to treating the cognitive impairment in Parkinson's. So think this slowness of thought, someone who might have a dementia correlated with Parkinson's disease. By targeting the receptors, you might see a lessening in these symptoms. All right, and then we have the CVT-301, which evaluates the effects of inhaled CVT-301, which is a version of the L-Dopa. And you use that rating scale to see how that affects their symptoms. The Unified Parkinson's Disease Rating Scale, to see if, okay, if we do an inhaled dose, does that have less of a does that have less side effects on the gut? So that's another ongoing clinical trial. Okay, so some resources for people with Parkinson's disease. We have the American Parkinson's Disease Association that explains symptoms and the differences between the signs and symptoms, what's normal, what's abnormal, emphasizes the importance of diet and exercise, and provides some great info on how to do so. So that's a really approachable thing for exercise. And the Parkinson's Foundation I talked about earlier, they're doing a great genogram study. They fund a lot of other studies as well. And they have information on everything from diagnosis, treatment, statistics. That's where a lot of the information for this PowerPoint as well has come from. Yeah, and then there's Parkinson's UK, which has a mental health hotline for Parkinson's disease, and it also hosts social events and webinars, and does fundraising as well. In Rochester, we have the Parkinson's Foundation of New York, New Jersey. The University of Rochester has some really great neurologists that our patient has utilized, and then we have our Upstate University Memorial University Hospital Movement Disorder Clinic. So our patient might be referred to that movement disorder clinic to see how can they advance and get better with their ADLs. Then you can find support groups in your area using that link below. Okay, here's some of our references. And I would definitely look at Parkinson's Foundation if you want to learn more. They had some really great resources. And then we have some articles there as well. Alrighty, that's it.